You're listening to Treating Blood Cancers, the LLS podcast series for professionals. We will be joined by cancer experts to discuss blood cancer diagnosis, treatment, side effects management, and the importance of clinical trials. They will share their experience in treating patients and discuss strategies for optimal patient care. Let's get the conversation started.
Welcome to Treating Blood Cancers, the LLS podcast series for healthcare professionals. I'm Dr. Ken Miller. I'm a medical oncologist, a hematologist, and an LLS volunteer. I want to thank all of you so much for joining us on this episode. Today, we'll be discussing survivorship care, including the long-term effects of cancer treatment, the importance of follow-up care, and the role of multidisciplinary collaboration in supporting the overall well-being of cancer survivors. We are delighted to be joined by Dr. Tisa Flores, who's the Medical Director of Cancer Screening and Survivorship at the Roswell Park Comprehensive Cancer Center in Buffalo, New York. Tisa, thanks for being with us.
Thank you so much for having me. This is very exciting to be able to talk about survivorship care, which I'm pretty passionate about.
Thankfully, with each year, the number of cancer survivors and survivors of blood cancers is increasing. So it's really a blessing to be able to have this be such an important topic. I'd love to get a sense from you in terms of what services you offer at your cancer center in terms of survivorship care as a place to start.
So myself and my team, we take care of cancer survivors by providing surveillance of their cancers and monitor for long-term effects and also screen them for secondary cancers. We also assess their quality of life to see if there are any supportive services that they might need.
So let me focus for a minute on one of the things you said about quality of life, just on a 60,000 foot level. Cancer survivors that you're seeing in your clinic, quality of life, if you had to sort of give an overall, assessment, rate A plus, B, C, D, and F, or in any system you want to use to describe it.
It is really variable on how many years they are out, what type of treatment modalities they received, if they have any long-term effects or complications from their treatment, and how much support they have. I have many patients who are years out and their quality of life is excellent. And then I have some patients whose quality of life are a lot of their emotional functioning and global functioning is lower. It's really dependent on how they have gone through this cancer journey.
So as we're starting to talk today about survivorship, one of the terms I've always liked is the seasons of survivorship. What are they from your perspective?
So I think we are now calling them phases. There's the acute phase where you are undergoing treatment. So that's the active phase or acute phase. And then there's the transition from active treatment to more intensive surveillance. And then you are in your extended or long-term survivorship. And as you know, survivorship, the nomenclature, the definition has changed over the years. People were considered survivors 5 years after their diagnosis and treatment. NCI now defines a survivor as at the time of diagnosis, and a lot of the patients don't embrace that because, at the time of diagnosis, getting treatment, they don't feel like a survivor. But that's how NCI sort of captures a patient population. And so a cancer survivor can be someone who is disease-free, who has metastatic cancer, who has lived a really long time and got a recurrence, or lived a really long time and got a secondary cancer. Cancer survivors is a really broad term. And when we think of seasons and stages, we think of acute, transitional, and then long-term or extended survivorship.
So in terms of these different phases, the acute phase, what would you say are the key issues for cancer survivors?
So the key issues for cancer survivors in the acute stage would definitely be how they are tolerating their chemo, if they are having any acute side effects. Obviously, a lot of them are unable to work, and if they have the support system. And then also finance would probably be a concern, but I don't think that's sort of top on their list.
Transition, how would you describe that phase? And again, priorities and problems for patients and cancer survivors.
So transitional stage is we're past the chemo radiation. We're starting to feel a little more like a human, but there's still the lingering effects of fatigue, maybe nausea, vomiting, depending on their treatments. And we're still doing the scans and the blood work. So we're still under the umbrella of the healthcare teams quite a bit. And so you're somewhat getting to normal, but not back to where you were before.
So a cancer survivor has gone through treatment. They've had this sort of transition to more of an observation phase. And my experience is that at some point, when the frequency of visits goes down, it's emotionally really challenging. So what have you seen?
There is definitely in patients who transition from 3, 6 months to a year surveillance, they do have this fear. Am I ready to be spaced out to a year and not see my oncologist for a year? What happens if my cancer comes back in that year's time? And I had mentioned that there is a fear of being abandoned. And I think it is important at this point to say that it is well known that during the acute cancer journey, a lot of the cancer survivors sever their relationship with their primary care doctor. And us specialists, us people who are in the cancer world, really need to be advocating for the patient to keep that relationship, because once the patients are in a extended survival and are spaced out to a year, they do still have other providers that they can see. So patients that I have, whether they're a cervical cancer survivor, they'll see me once a year and see their gynecologist the following 6 months. So they still get a sense of being surveillance more often. And when a patient is a long-term survivor, a lot of times patients are graduated to the community. And this is important for the patients to feel like they can follow up with their primary care doctor. And on the other flip side, making sure that the primary care doctors feel comfortable following these patients.
So, and I can't say I'm going to play devil's advocate, but let me just go ahead and
Play devil's advocate. Let's do it.
I'll do it. Sure, let's do it. I wonder to myself, when someone is 15, 20, 25 years out from colon cancer, from, let's say, from breast cancer, from lung cancer, do they need to keep seeing their oncologist? I mean, many are not at that point, but some are. And so, what are your thoughts on that? What is the most important priorities in their care?
Oh, this is a loaded
It
question.
is. That's why I
It is a
asked
loaded
it.
question. So, right now, there are about 18 million cancer survivors in the United States. There are about 1 million cancer survivors in New York State alone. By 2040, there's going to be 26 million cancer survivors, and the majority of these patients are going to be over 65 years of age. With an emphasis in cancer screenings, we are now diagnosing more cancers, and the oncologists really should be focusing on these newly diagnosed patients. So patients who are 15, 20 years out, I feel do not really need to be seen by oncologists. I mean, there's definitely some patients that I would keep, an AYA, leukemia, because we know that with their treatments, they are increased risk for secondary cancers. Having them see a survivorship clinic would be ideal. I know not many places have a survivorship clinic, but that way they're still in the cancer realm, the cancer health system, but not in acute oncology, and also sort of not in primary care, knowing that they are increased risk for secondary cancers. But the colorectals who are 15, 20 years out, at that point, their surveillance is a colonoscopy. We don't even do CTs. If their blood marker, their CEAs were elevated, we may or may not follow those. But at that point, same thing with breast cancer survivors. When they're that many years out, their gynecologist or their primary care physician or provider can obtain the mammogram.
I agree with you. But part of it is oncologists rarely use the term cure. So we look at patients as needing ongoing care. And I think for many, they really can transition. Is there pushback from the oncologist about discharging patients or referring them for survivorship care?
I mean, oncology buy-in is part of the issue. There is the emotional attachment that the oncologists have to the patients, right? They love seeing a patient that they treated 10, 15 years ago and they're still healthy and they're thriving. So there's the emotional part of it for the oncologist. And then there's also the question of someone like me who is not an oncologist, but is an oncogeneralist, so a primary care physician who has special interest in special training in oncology and cancer survivorship. There is concerns of whether or not me and my staff will know what to look for.
So will you?
Well, yes, because I happen to be in a cancer center. So if we see anything abnormal, it's easy for me to reach out to my oncologist colleagues and say, hey, I have this case. What do you think of it?
Because I've heard from the oncology side, it's important to have oncology follow up as someone may develop congestive heart failure or may develop pulmonary issues. My own view has been that primary care doctors do this work all the time. Does that sound fair?
That is very fair. I would have to ask how many oncologists have actually managed stage 4 congestive heart failure from the cardiotoxic therapies we've given patients.
No, I totally agree with you. Let's talk for a few minutes about long term emotional and psychological and psychosocial issues for cancer survivors. And you've been talking about this very large number of cancer survivors. So, how can we address those needs the best?
So, fear of recurrence, anxiety, and depression, sort of what we call the emotional function, is a heavy burden on our cancer survivors. The National Coalition of Cancer Survivorship does a survey every few years, and it sends out to cancer survivors, and they ask what is their most common side effects. And last year's 2024 survey said that 42% had fear of recurrence, and then 32% had depression and anxiety. And rightfully so. Cancer is one of those things where it happens, and whichever cancer you have kind of makes you feel like you have no control over your life. You
Hmm.
could have been, you know, 20, 12, and
Yeah.
gotten leukemia, and that was not your fault. So they have every right to feel anxious, concerned. I think a big part is making sure that they have a good support system and a support system from day one, obviously offering psychotherapy, whether it's an LCSW or a psychologist, and as a psychiatrist. I would push and press that you should have a counselor or a psychologist that does have a cancer background, because there is definitely psychological distress that happens with cancer survivors. When I used to practice primary care, I would see patients who would have heart attacks and strokes. And if they had heartburn, not everyone would go, oh my God, I'm having a heart attack. But a cancer survivor might have a twinge in their back or their rib or their spine. And one of the first places they go to is, oh, my cancer has returned and it's in the bone. Or
Right.
do I have
Yeah.
bone cancer? So, I mean, it's a different mindset. And that's something that we have to understand. If a patient has complaints, we should also hear them and also either say, yes, this is a concern, or no, I don't think that this is cancer and this is the reason why. And a lot of the patients feel like sometimes when they're that long term, their concerns are not heard.
Yeah. Yeah. Absolutely. What are some of the issues that you're seeing and let's say long-term cancer survivors?
So the extended survivors, sort of, we're talking 10, 15 years out.
Yes. Yeah.
Fatigue, amazingly, is still one of the biggest complaints. The fear of recurrence is a big one, especially if you are a young adult or an adolescent who is treated for their liquid tumors. There is a lot of fear of a secondary cancer, financial toxicity. We're starting to understand that there has been a lot more financial issues that we didn't really address when they were receiving their cancer treatment. There's a lot of questions of sort of how to maintain your energy throughout the day. And there's always concerns of like, will I be there in 10, 15 years?
I'd love an example of someone you're seeing who's a cancer survivor in your clinic and some of the issues they may be having.
So I have a patient who is a non-Hodgkin's lymphoma survivor. I think she was diagnosed when she was 18, and she is healthy, but she was young when she was diagnosed. So let's call her Connie. So she was in high school. She had very supportive parents, and she actually went into nursing school and became a nurse practitioner. And she is currently working at a cancer hospital. So, one of the things for her is she is anxious because of her young diagnosis. She was fortunate that she was able to have a child because there is a lot of oncofertility concerns in the AYA population, because a lot of times when they get diagnosed, treatment is quick. So there is little time to either harvest eggs or preserve sperm. And she ended up being diagnosed with breast cancer at 37. She did not get radiation, but she felt a lump in her breast and it was breast cancer. So her anxiety of, could her cancer be back? Could she get a secondary cancer? Did happen. And
Yeah.
she did, everything right. She
Yeah. Yeah.
exercised, she didn't drink, she was a normal weight. So all the things that we think of when we think of breast cancer survivors, like we know that alcohol use and being a little bit heavier increases your risk of breast cancer. She didn't do any of that. She has completed treatment of her breast cancer and she's doing well, but she's doing well because she has a really good support system and she
Mhm.
sees a psychologist. So when she had to undergo her treatment of her breast cancer, she started to see the psychologist more frequently.
So a lot of her challenges have been a second cancer and the psychosocial.
Yes.
We talked about some of the psychosocial issues. What are some of the special comorbidities that cancer survivors may have or develop later in life that primary care physicians are tuned into?
With a lot of our cancer treatments, we are now learning that they are cardiotoxic. So I think it's important for cancer survivors and primary care providers to understand what cancer treatments they have so that there is a lower threshold for cardiac workup. If you
Mhm.
are a 40-year-old female who got radiation and adriamycin or something, your primary care doctor may not think, in addition to a long distance runner, at 40, your primary care doctor is not going to be thinking that your shortness of breath when you go up 3 flights could be related to your heart. But it
Yeah.
is something that primary care providers should be aware of. And as we age, going to 60 and 70, we already know that heart dysfunction happens just from all the other issues of aging and hypertension and diabetes. So, just sort of having a lower threshold to consider the aging process of my patient. So, the chronic medical issues of metabolic disorder, cardiac dysfunction, is it normal aging, normal disease process, or could it be compounded by their cancer treatment, cancer history?
What would you consider if you or if I had the ability to change the system or have an optimal system? What would constitute sort of the best possible care for cancer survivors?
In my dream world, it would be great from day one when we diagnose them, because a lot of times with diagnosis, it comes from the outside. It's not like the oncologist sees them. From day one, we actually work as teams. I think there's a lot of siloing in the healthcare. So once primary care doctor, we're talking internist, family medicine, gynecology, diagnoses some sort of cancer. The cancer goes to the oncologist. The oncologist treats the patient, and then hopefully, after successful treatment, comes back to the community primary care provider. It would be, in my world, nice to have health systems, EMRs, to actually communicate what's going on with our patients. So once they're done, it doesn't feel like there was a gap in care, because I think a lot of issues is that there is a gap in care.
Yes.
I saw a patient who had a AAA in their CT scans, and he was diagnosed with cancer, and they were so worried about the cancer that they forgot about the AAA. And then when they finally saw
Wow.
me, and I'm like, "Hey, do you know about this AAA?" They're like, "Oh God, yeah, we were so," and at that point it was like 5 centimeters. And I'm like, "Okay, I need to get you
Yeah.
back to a
Yeah.
vascular surgeon." And 1 year after I navigated him back to the vascular surgeon, he had surgery.
Yeah. Yeah. Interesting. So again, emphasizing the power and the knowledge of someone who's in primary care, who's trained to look at the
Yeah.
bigger picture. So thank you. I believe that everyone should have a primary care provider. And let me ask you, how does someone find that? And what should a cancer survivor look for in a primary care provider?
So I think all patients, not just cancer survivors, should find a primary care provider that they are comfortable with and feel like they, being the primary care provider, listens to the cancer survivor's concerns. I think is the biggest thing, is making sure that there is a good relationship there in both sense. Not every place will have a cancer survivorship center like the institution that I work at. So I strongly feel that oncologists should be working with their local primary care providers to educate their colleagues on the treatments that the patient got and their possible long and late term effects. Because primary care doctors manage thyroid disease, hypothyroidism with levothyroxine. They manage
Right.
congestive heart failure. So they understand the medical disease and treatment. So there just needs to be a communication between the services, the specialty of what happened during treatment and what could possibly happen now that they're in survivorship. And also screening for other cancers. I think a lot of times when a patient goes into the cancer world, there are assumptions that the oncologist is screening for other cancers. And sometimes the oncologist will think that the primary care is doing it. So I think it's important to uh, designate who is doing what.
Absolutely. You were talking earlier about AYA cancer survivors. Are there other groups that come to mind that have their own special needs that would be important to sort of keep in mind, whether they be cultural or communication, et cetera?
There are many groups that we have to keep in mind. So when you mention specific patient populations, one of the first ones that comes to my mind is the patients who are transitioning from their biologic sex to the
Yeah.
sex that they
Yep.
identify with. So if you have a patient who is born a male and is
Hmm.
transitioning to a female and she is on estrogen,
Yep.
there is an increased risk of breast cancer because of the higher dose estrogens that they are on. But if they haven't completed their transition, we need to worry about their prostate.
Yes. Yep.
So there are many populations that are special, I guess, like the AYA, the LGBTQA plus. We know that a lot of lesbians do not feel comfortable getting cancer screening. And then there are the cancer survivors who have had immunotherapies. The oldest ones now are 20 years out, and there's so many new ones, but they themselves have a lot of autoimmune toxicities.
Yeah. Yeah.
The cardiotoxicities, the dermatitis, the nephritis, and
Yeah.
there aren't a lot of guidance on what should we do with them. They had the acute toxicity. Hopefully they've recovered, but we don't know 20 years down the road, are they more likely to get colitis, uveitis,
Yeah.
all the itis.
Very good point. And hopefully, the development of immunotherapy and targeted therapies is now just the beginning of what we'll see in terms of treatment options. So, your point's well taken about the survivorship field. Part of what it can do is sort of monitor for these very late kind of changes. I personally happen to like the report card sort of paradigm, but in any way that you'd like to evaluate it. Care plans. Let's talk about those survivorship care plans. The concept and the execution of them. Again, is this what we're doing or what's been proposed in A plus or a C or an F or just your view on it?
I think the intent was an A++. I think how the institutions attempted to roll out care plans was an F.
Okay. Yeah.
So I think when we were rolling out with like the COC, it was just sort of a metric of we have to get so many care plans out there, right? ASCO has a guideline on how to do it, but it was more of like we need 60% to have care plans. And it really was dependent on whether or not people bought into the care plans. I personally love care plans. My team makes care plans on the majority
Yeah.
of our cancer survivors because we want to bridge the gap between us
Yes.
and the community. So we do have survivorship care plans for our patients. But I think instead of having a survivorship care plan, if we actually had, say, your progress note talks
Yes.
about
Yes.
the possible complications, that works also. Just sort of
Yes.
a
Yeah.
communication, a piece of paper that tells you, me, oncologist, you, primary care, these are the things that we as a team need to manage and look for. I will be obtaining the DEXA scan because the treatment I gave had the increased risk for osteoporosis. You, primary care, give them the flu shot, sort of denoting who's doing what.
Yeah, yeah. And your point's well taken that maybe not in the form of a care plan, but even just a progress note, a letter, et cetera. And finally, I wanted to ask you about, again, if we were to say that one of the goals of survivorship care is healthy survivorship, is people living well beyond cancer. What are the key things, recommendations you make to cancer survivors about healthy survivorship?
I love this question. So that is a tenet of survivorship care is preventive care. So making sure that you are up to date with other cancer screenings, cervical, prostate, colorectal, lung, making
Yep.
sure that you are following with your primary care doctor or primary care provider to ensure that all your other chronic health conditions are under control. I am a really big advocate for AICR or WCRF recommendations. It's on the web and it really talks about healthy lifestyle, talks about 30 minutes of exercise 5 days a week, really limiting your alcohol, limiting your consumption of high fructose corn syrups and ultra processed foods, wearing sunscreen. I mean, common sense
Yeah.
cancer prevention. And it's actually taking care of yourself. It's cardiovascular prevention, diabetes prevention. So I'm a really big proponent. So WCRF, World Cancer Research Fund, it actually talks about if you have a specific cancer, these are the things that increase your risk for a recurrence. These are the things that decreases your risk for recurrence. And then just overall things that you could do to decrease your risk of having a cancer. It's definitely one of the things I talk about with my patients. But really stressing making sure that they are taking care of themselves and making sure that they are participating in other cancer screenings that they're eligible for.
Yeah, definitely. All right. Thank you. Again, this is Dr. Ken Miller. I want to thank all of you for listening to this informative and truly terrific episode. I also want to say a special thank you to Dr. Tisa Flores, who is the Medical Director of Cancer Screening and Survivorship at the Roswell Park Comprehensive Cancer Center. Tisa, thanks so much.
Dr. Miller and Leukemia Lymphoma Society, thank you so much for giving me the time to talk about one of my passions.
Thank you. For our listeners, if you'd like a listing of all of our healthcare professional continuing education activities, podcasts, and healthcare professional resources, including a fact sheet on facilitating optimal survivorship care for blood cancer survivors, please visit lls.org/CE. For any questions or to refer a patient to LLS, please contact our Information Resource Center by calling 800-955-4572. Information specialists provide personalized one-on-one support to help patients learn about their disease, treatment, financial, and support resources that are available in English and Spanish, including survivorship workbooks and caregiver workbooks for adults, children, and adolescents, and also young adults. LLS also provides other resources for patients, survivors, and their families that can be found at lls.org/support. And I encourage you to sign up to receive notification of future podcast episodes by subscribing at treatingbloodcancers.org. If you have suggestions for future episodes, please click the feedback button on this episode page, and we look forward to you joining us on future episodes. So over the last 3 years, we've done some really interesting podcast episodes on cancer survivorship. And I know that this is an ongoing topic of interest for all of us who are taking care of cancer survivors. And I want to encourage you to listen to some of our previous podcasts, as well as the episode we're presenting now. And you will find on the webpage links to bring you to some of those other podcasts. And I hope you enjoy them and find them to be a good resource.
Thanks for listening to Treating Blood Cancers, the LLS podcast series for professionals. We can be found on iTunes and other podcatchers. You can subscribe at www.treatingbloodcancers.org and provide your suggestions for future topics. Visit our archives section on our website for other great podcasts. Be sure to rate and review us on iTunes. Keep up with LLS by following us on Twitter at LLSUSA and on Facebook at the Leukemia and Lymphoma Society, and access our professional continuing education activities by visiting lls.org/CE. Let's keep the conversation going. Until next time.